We are talking about parasites, and the parasite of interest today is Interamoeba histolytica. It's an amoeba, right? So in parasitology, when we are discussing parasitology is divided into three components. You have got the study of worms, that is known as a helminthology. Helminths are worms. They are not also known as metazoa. You can also study insects that can cause diseases. For example, things like flies, mosquitoes. Those are arthropods. And then you also have protozoa. Protozoa, these are unicellular organisms. So in today's class, we're talking about Interamoeba histolytica. It's actually a protozoa. So if you see, we can divide protozoa into Apicomplexa and Sarcomastigophora. These are the two big classifications. In Apicomplexa, these guys have got similar features. They include Plasmodium, the guy that is causing malaria. This is the parasite that causes malaria. We also have Babesia, which causes what is known as babesiosis. We also have got Toxoplasma gondii, which causes toxoplasmosis. So these are known as apicomplexa. For the other group, the Sarcomastigophora, I don't want you to master that term. If you want, you can master it, but it's not bad. You are going to have parasites that have got flagella. You know, flagella are these things that are used for movement. In first year, you looked at the general shape of a bacterial cell, and we said that they have got flagella for movement. So those parasites that have got a flagella, you call them flagellates. And then you have got amoeba. Amoeba are type of protozoa that don't have any flagella. Okay. So again, for the flagellates, these guys that can move because they've got a flagella, you have got those which are found in blood. We call them hemoflagellates. You have got those that are found in the intestines. We call them intestinal flagellates. Those that you find in blood, the hemoflagellates, we have got leishmania, which causes the disease known as leishmaniasis, and then the trypanosomes, which will cause a trypanosomiasis. Okay. And then the intestinal is we have got Giardia, Lambia. Each one of these which we are mentioning is actually a topic on its own. Plasmodium, that's a topic we do discuss that later. Babesiosis, toxoplasmosis, leishmaniasis, trypanosomiasis, and then Giardiasis, we also discuss that. Now, for the amoebas, we have got those that are found in the intestines. We call them, these are actually, most of them are non-pathogenic. In other words, they don't cause any infection. Of all the amoebas that are found in the intestines, only one is of medical importance that we are going to study, and that's known as Interamoeba histolytica, or E. histolytica. And then please don't forget that I've said that most of them are what? Non-pathogenic. So the non-pathogenic amoebas, we also call them as free living amoebas. These are opportunistic parasites. They can only cause infection if they find an opportunity. Opportunistic. So an exam question can come to say, oh, free living amoebas are they are opportunistic parasites. They normally don't cause infection, except Interamoeba histolytica. It is a pathogenic one. Examples of non-pathogenic or free living opportunistic amoebas, we have got Naegleria fowleri. When we are discussing head and neck, I did mention this protozoa, Naegleria fowleri. I said that it is going to penetrate through the equilibrium plate via cranial nerve number one, and then it's going to cause infection of the central nervous system. We also have what we call Acanthamoeba, and then Balamonthia mandirasis. So these ones we're supposed to discuss. So today we are discussing Interamoeba histolytica. In discussing everything that you talk about in microbiology, you're supposed to understand the morphology. What are the shapes of that parasites that you're talking about, or that microorganism? What is its life cycle? what is the pathogenesis? How does it cause disease? And if it causes a disease, what are the features of the disease it will cause? For example, okay, this thing is going to cause a disease, and then you are going to be having diarrhea. The diarrhea is bloody, such things. Those are clinical features. And then you want also to see, okay, someone has got this infection. How can you confirm in the lab that they have got this infection? So that would be the laboratory diagnosis. Diagnosis is you being able to tell what disease someone has by looking at clinical features, by looking at the presentation of the disease, and by looking at the actual organism, the way it is looking. And you also are supposed to understand the treatment for these diseases and how you can prevent. Actually, this is the outline for everything that we discuss in microbiology. That's why it seems to be a bad course a bit because of all of this. All right. So amoeba, these guys have got a membrane. They are protozoa which are bound by a membrane. They don't have a fixed shape, meaning that they can change shapes anytime, anyhow, and they can be classified, as we said earlier on, as the free living, which are opportunistic, or those which are found in the intestines, the intestinal. This is where you find in Amoeba histolytica. The cytoplasm of these amoebas has got two. So these guys have got two membranes. You have got an ectomembrane and an endomembrane. So the endo, the one which is inside, is actually going to be these membranes are going to be used for, apart from movement, also for phagocytosis. You can see the way they are looking. And their membranes are more like making these folds to form what is known as a pseudopodia. Pseudopodia is going to be used for phagocytosis, all right, to trap something like that. So you can see the outer membrane is the ectomembrane, and then the inner one is the endomembrane. So meaning that they are also going to have two cytoplasms. The cytoplasm that is outside the membrane, that is known as ectoplasm. So there is a plasma membrane, which is, there is the cytoplasm which is outside the endo, that is the ectoplasm. And then there's the cytoplasm that is inside the endoplasm, that is inside the endomembrane, that is the endoplasm. Okay, so that will form the cytoplasm. Please take note of that. So how do these guys reproduce? They are going to reproduce by what we call binary fission. You know, binary fission is just something being able to divide on the middle, and then you have got two. And then these guys are also going to have, they can also divide by budding. All these things you can see are exam questions. So how do amoebas divide or reproduce? Binary fission or budding. So what happens is that these guys have got different shapes, and depending with the conditions. So if the conditions are good, right, they are going to transform into the form that can be able to divide. If the conditions are bad, they'll transform into the form that can't divide. In other words, they are transforming into the form that is resistant to the harsh environment. That is the unfavorable condition. So that statement is important for you to understand. When we are classifying amoebas, we've said we can classify them into intestinal amoebas and the free living amoebas. The intestinal amoebas, we have got Entamoeba histolytica, Entamoeba dispar, Entamoeba coli, Entamoeba gingivalis. Now, these three, they are non-pathogenic. They normally don't cause infection. Of course, they're found in the GIT, but they don't cause infection. You find them as part of normal flora. But Entamoeba histolytica is pathogenic. And then you have got those which are freely living amoebas, which are also known as opportunistic parasites. They can cause infection when conditions become favorable. Naegleria fowleri, Acanthamoeba species, Balamonthia mandrillaris. And we have said that all free living amoebas are opportunistic infections or pathogens. So let's go with Interamoeba histolytica. Interamoeba histolytica was first demonstrated in feces of someone that had dysentery. You know, dysentery, this is where someone has got bloody diarrhea, right? That is dysentery. When you look at cholera, vibrio cholerae, that's a bacteria and it causes diarrhea, but the diarrhea is watery. Interamoeba histolytica causes diarrhea also, but that diarrhea is going to be bloody diarrhea. That's known as dysentery. You also have the bacteria known as E. coli. Now, E. coli has got 5 species. Some of them cause bloody diarrhea, some of them cause watery diarrhea, but that's a discussion for another time. So Interamoeba histolytica has got 22 strains. Out of these 22 strains, 9 are invasive. The meaning of invasive is being able to penetrate through tissue. See, if you get something, you throw it in your mouth. That is not being invasive. Being invasive means penetrating through tissue. So if something you've eaten goes into your GIT, then it penetrates through epithelium to go into your cells. That's now called the invasiveness. Okay. So of the 22 strains of Interamoeba histolytica, 9 are invasive. The rest are non-invasive commensals. What are commensals? These are microbes that reside on the surface of the body or the mucosa without causing any harm. So meaning that if you eat them, like if they are in your GIT, they'll just be in your GIT. They can't penetrate the GIT epithelium. Hope we've gotten that. That's the meaning of non-invasive commensals. We live with them. Now, Interamoeba histolytica has got different morphologies. It has got different shapes. Okay. It has got what we call the trophozoite. This is the one that you can see here. And then we have got what we call the cyst and then the precyst. So one thing you need to know is that Interamoeba histolytica, when you look at the trophozoite of Interamoeba histolytica, inside the trophozoite, there are red blood cells. In other words, this bacteria ends up chewing, engulfing, phagocytosing our red blood cells. But Interamoeba dispar does not, the trophozoite of Interamoeba dispar does not have any red blood cells. But Interamoeba dispar can eat bacteria. Do you get that? This can come as a multiple choice question for you to differentiate Interamoeba histolytica from Interamoeba dispar. This is a parasite. It can chew bacteria, but it can't phagocytose red blood cells. Interamoeba histolytica can do for both. Epidemiology, how is disease spread? This dysentery that is caused by Interamoeba histolytica it's actually prevalent worldwide wherever sanitation is bad, okay, but most common in the tropics. And majority of the infection, if someone has got Interamoeba histolytica, is actually asymptomatic. You will not see any symptoms. The person will be just normal like that. It's the third leading parasitic cause of death after malaria and schistosomiasis, which is known as bilharzia. So malaria is the first parasitic cause of death, followed by bilharzia or schistosomiasis. The third one is Interamoeba histolytica. You can see how bad it is. Not sickness, but the third cause of death. How about immunity? How does Interamoeba histolytica affect immunity? So infection with invasive strains, those that can penetrate through the GIT or wherever they can penetrate, will lead to both humoral and cellular immune response. You know the humoral immunity? This is where there is the cellular, this is where you have got the T cells, the humoral, you have got the B cells. So when these guys penetrate through they become invasive, they penetrate through tissue to go into our blood and going into other body parts, they can activate these B and T cells. Serological response is not seen in infection with non-invasive strains. The meaning of that is that the B cells and T cells are not going to be activated when you have got those strains that are not invasive, those which cannot penetrate through the epithelial surfaces. And antibodies can be demonstrated within a week of invasive infection. So what happens that if you have got Interamoeba histolytica, it penetrates your GIT, or it becomes invasive, it goes into blood. what will happen is that the body will start producing antibodies against the antigens of the parasite, and you can see them 1 week after the infection. Okay, so meaning that if someone gets sick today, you might not be able to see the antibodies. So if you are trying to diagnose, you are trying to confirm if someone has got amoebiasis, and you are looking at antibodies, they might not be seen if the infection just started, like if invasiveness started today, because you can see the period that it takes, right? So that will not be a reason for you to say someone doesn't have amoebiasis because you have not seen the antibodies. Some degree of protection occurs after an infection, as shown by the low case of recurrence of invasive colitis and liver abscess in endemic areas. So, in other words, when you get to some degree, when you get the infection for the first time, you can be protected a bit later. And the course and severity of amoebiasis does not seem to be affected by HIV infection. Whether you have got HIV, you don't have HIV, this one can hit you and you can be really, really sick. So, what are the morphologies? What are the shapes of Entamoeba histolytica? So, as we said earlier on, we said that Entamoeba histolytica has got the trophozoite, the precyst, and the cyst. So, you need to know how these guys look: trophozoite, precyst, and cyst. When you look at the trophozoite, it is irregular in shape, is actively motile, growing stage of the parasite. So, the trophozoite shape or morphology of Entamoeba histolytica is the one that moves. The others don't move. The other forms. So meaning that if Entamoeba histolytica changes from trophozoite to cyst, the cyst can't move. Wherever it is, that's where it stays. But the trophozoite is the one that moves, and this is also the growing stage. So the cyst can't grow. It is actually the trophozoite that which is the growing stage, and it's only the trophozoite that is present in tissues. Okay, in our tissues, in our body, it's only the trophozoite. You will not see the cyst in the tissue. The trophozoite, again, for Entamoeba histolytica, remember, as we said, it contains phagocytosed red blood cells, and this is actually a diagnostic feature for Entamoeba histolytica. And we said that this feature is not present in commensals like Entamoeba dispar, those guys which will not be able to penetrate, which are not invasive. Trophozoites can actually be killed by drying, heat, and chemical sterilization. To sterilize something is means to do away with any foreign substances from that surface. Let's say, for example, before you perform a lumbar puncture, you are going to get spirit, you put on that place, you bring other things, you put there, you are cleaning the area. That's to make it medically clean. That is sterilization. Sometimes you can also use the heat to sterilize, for example, medical instruments. The trophozoite is going to divide by binary fission in every 8 hours. It's an anaerobic parasite. The meaning of that is that this guy loves where there is a lot of carbon dioxide. It doesn't love where there is oxygen. Okay, it can survive where there is no oxygen. That's anaerobic parasite. And I've said that this is the form that is going to be able to divide, to grow, and it's actually the feeding form to be able to grow. Large and actively motile in fresh past stew. When someone who has got dysentery goes to the toilet, their stool, you are able to see trophozoites there in fresh dysenteric stew. So that can be used for diagnosis. So you cannot transmit infection using this trophozoite. Why? Because it is quickly destroyed in stomach acid. So let's say, for example, one person that has got dysentery went and helped themselves. That date touched the veggies, the vegetables, and then you came and got those vegetables or maybe a fruit. You forgot to wash it, you ate it. Because the stew contained trophozoites, those trophozoites, even when you ingest them, they cannot cause infection to you. Why? because once the trophozoite reaches the stomach where you have got acid, the trophozoite is going to be destroyed by acid. That is important to know. Okay, so that's why it cannot, the trophozoite form is not the form that can transmit infection. This form can actually survive up to 5 hours at 37 degrees Celsius, but you can kill them using heat, drying, and chemical sterilization, as we said earlier on. Okay. So when you stain the trophozoite with hematoxylin, you know this is a stain, H and E if you remember, they are going to look grayish, and the red blood cells inside are going to look pale. And when you stain this using the trichrome stain, they will look greenish. So that's a trophozoite. Again, you can see this is the trophozoite here. Inside, you can see the ingested red blood cells, and then you have got the nucleus there. The second form of this parasite is the precyst. The precyst, what happens is that the trophozoite is going to go what is not undergo what is known as insistment. This word. So I need you to differentiate these two. If there is an X here after E, there is an X that is known as existment. This is insist. So to insist is to become a cyst. Exist is to move from a cyst into another form. So before a trophozoite can become a cyst, that is insistment, it actually does that in the intestinal lumen. Please take note. We said earlier on that the trophozoite is the only form that is found where? In the tissue. Therefore, for you to form a cyst, you can't form a cyst in the tissue because it's not found in the tissue. That can only happen in the intestinal lumen. Okay? Or so what is going to happen is that uh, once we have got this trophozoite, it has to change into the cyst. The the trophozoite is going to extrude, is going to remove what is known as the food vacuum. Please take note. This is a food vacuum because in multiple choice questions you can see they might put another vacuum there. This is a food vacuum that is going to be removed. So once the trophozoite removes the food vacuum, it is now going to become round. Remember, it was not round. It had a morphology that was irregular. Once that happens, it has formed the precystic stage, and that's the one that we can see here. So the precystic stage contains a large glycogen vacuole. You can see this is not a food vacuole, but a glycogen vacuole and two chromatid bars. They can actually bring a multiple choice just on this one, the morphology of the precystic stage. It has got one large glycogen vacuole and two chromatid bars. Okay. So again, the precyst is smaller to trophozoite, but is going to be larger than the cyst, which is the next form. It has got some pseudopodia, blunt pseudopodia, food vacuoles, and red blood cells disappear because we said that the food vacuole is actually extruded from the trophozoite before it becomes a precyst. And then it has got a single rounded nucleus. It doesn't have any ingested material, and there is no cyst wall. The cyst has got a wall, but this one doesn't have a wall. So the next phase is known as a cystic stage. The cystic stage, what happens is that the precyst is going to secrete its highly rectal cyst wall. Once it excretes that cyst wall around it, it is going to now become a cyst. This is a rectal cyst wall that is going to be removed. Now the cyst has got three forms. You have got the early cyst, which contains only one nucleus. You have got now another form of a cyst that contains two nuclei. And then those two nuclei, actually what is happening is that if the early cyst has got one nucleus, once it divides, it's now going to be two nuclei. Once those two, each one of them divide, you're now going to have four nuclei. That's now known as the mature cyst. The mature cyst has got four nuclei, and we call it a quadrinucleate cyst. And this cyst contains one nucleus. So the early cyst is going to have one nucleus, one glycogen mass, 1 to 4 chromatid bars, differentiate from the pre-cyst which contained the one glycogen mass and the two chromatid bars. The cyst is the one that is going to be used to to transmit infection. Why? Because it is highly resistant to stomach acid. So once you get this cyst, it goes in your body. It can be destroyed by the acid in the intestines. Okay. So in other words, it is resistant to unfavorable environments. That is why every time there is an unfavorable environment, what happens is that there's going to be insistment. The trophozoite is going to form the cyst because the cyst can withstand bad environment. And take note of this feature. The cyst has the nucleus has got what is known as a cartwheel appearance karyosome. Okay. The karyosome is going to be looking around. This is just the genetic material. So we are saying that as the cysts mature, the glycogen mass and chromatidial bars disappear and the nucleus undergoes two successive mitotic division to form two and then four nuclei. So the mature cyst has got four nuclei and it is resistant to this stomach acid. Okay. So you can see the nucleus was just one here, but by the time it becomes mature, you have got four nuclei. And then you can also see there is also a cyst wall. And then you have got two chromatid bars and then one glycogen mass here, the one that you can see in white there. Now that we know the morphologies, you need to know the life cycle. How do you get the infection for that is caused by entamoeba histolytica, known as the amoebiasis, because this is amoeba. So the infective form, the form of the parasite that causes disease is the mature quadrinucleate cyst. And this guy is actually passed in feces of the carriers. Okay, the mature cyst. Please take note that it's mature quadrinucleate, the one that has got four nuclei. And what's the mode of transmission? Man can get the infection by swallowing food and water that has got the cyst. What happens that this cyst is going to go into the stomach, but it is resistant to the stomach acid, and so it will be able to pass. And then excistation will happen. Excistation is now for the transformation from cyst to trophozoite. Please understand where this happens. So the cyst is going to reach the cecum, okay, which is part of the beginning of the large intestines or the lower part of the ileum. So basically the end of the small intestine to the beginning of the large intestine. That's where the cyst is going to reach. And because the environment there is alkaline, the cyst wall is going to be damaged by trypsin, and that leads to the excistation. The cyst will remain viable under moist condition for about 10 days. So if the conditions are moist, it can remain viable. It will not be able to die. So this is a simple summary of the life cycle. You have got a cyst. The cyst can undergo excitement or excistation to form the quadrinucleate amoeba. So this one has got four nuclei. That's known as a metacyst. And then the metacyst is now going to undergo divisions to form eight nuclei. Remember, the metacyst contains four nuclei. So if this if this metacyst divides on the middle, everything that it has will also divide. Okay. So the each one of the nuclei is going to divide. So from the four, if all the four nuclei divide, we are now going to have eight nuclei. And then what will happen is that the cytoplasm has not yet divided. It's only the nuclei that are divided into eight. And then those eight nuclei, what will happen is that each nuclei is going to be surrounded by its own cytoplasm. And so you are now going to end up with eight small amoebulae or metacystic trophozoites. These metacystic trophozoites now will go to the submucosa of the cecum and colon. in the glandular crypts, the crypts of Libacon, and then they'll be able to grow by binary fission. Remember, we said that the form that can grow is the trophozoite, right? Now that we have formed the trophozoite, thus now is going to undergo growth by binary fission. Some of the metacysts is going to develop into a pre-cyst and then will form a cyst, which are going to be passed into feces, because this is like in the cecum and the colon, to continue to repeat the life cycle. So you can see this guy is taking water that is dirty. It's just that you can't see what is happening is that they ingest a cyst from the contaminated water, or the food is going and then it undergoes existment. Okay, existment, what you are forming is the quadrinucleate metacyst, and this is happening on the lower end of the ileum to the beginning of the cecum. And what will happen is that this quadrinucleate metacyst here, each one of them is going to divide. The nuclei are going to divide. When these nuclei divide, then each one of the nucleus is going to carry a cytoplasm. The cytoplasm, now you have formed the daughter amoebae, and there are 8 of them. These 8 of them, what will happen is that some of them can become invasive. They can penetrate. You can see they'll penetrate the trophozoites, can colonize the large intestine here, the colon, and that is what is going to actually lead to blood coming out, and so someone can have bloody diarrhea. Beside, away from being able to colonize the GIT, some of these will undergo encystment. They will form again the cyst. Okay, this trophozoite can form the cyst again. This cyst again can form the binucleate cyst and then quadrinucleate cyst. That quadrinucleate cyst can go into the feces. In the feces, someone, maybe the feces contaminate water or food, that can be taken by a second human, and then the life cycle continues. That's how infection is able to spread. Okay, so in most cases, Entamoeba histolytica remains as a commensal in the large intestines. It will not cause any ill effects. So such people that have got the Entamoeba histolytica without causing effects, those are carriers, asymptomatic carriers. However, it can be also activated, and that is what leads to the clinical disease of Entamoeba histolytica. Okay. So latence and reactivation are the characteristics of amoebiasis. Latence is a period when you can't see any clinical manifestations. So you have got the infected host. It can either be symptomatic or asymptomatic. The asymptomatic ones are carriers. The symptomatic ones, you can have intestinal disease that is known as amoebiasis, intestinal amoebiasis. Again, the amoeba can actually leave the GIT and go to other body parts like the liver. The liver is actually the first that can be attacked. So that causes what is known as extra intestinal amoebiasis. Okay, so that is what happens. So the pathogenesis, how do these guys cause infection and what are the clinical features? The diseases that are caused by Entamoeba histolytica, we have got intestinal amoebiasis and extraintestinal amoebiasis. Incubation period is 4 days to 4 months. Incubation period is the period in which you are going to have the infection, and then before you can start developing clinical features. So meaning that you can actually get this guy, you don't have infection up to 4 months, and then after 4 months, then infection can happen. Please take note, 4 days to 4 months. Okay. Amoebiasis can present in different forms and with different severity degrees. We have said we can either have intestinal amoebiasis or extraintestinal amoebiasis. The intestinal amoebiasis normally is affecting the large intestines, which is the site where the parasite is going to be able to penetrate the GIT. Extraintestinal amoebiasis, this is where the amoeba now goes to other body parts. For example, if it goes to the liver, it will cause hepatic amoebiasis; to the lungs, pulmonary amoebiasis; to the brain, cerebral amoebiasis; to the spleen, splenic abscess. But the most common of the extraintestinal amoebiasis is actually the liver, hepatic amoebiasis. One important feature that you need to know about intestinal amoebiasis that you are going to find in your exam is Of course, amoeba does not cause illness until it invades the intestinal mucosa. We said so, isn't it? Most of them, that's why they're non-pathogenic, because they can't penetrate the mucosa. But once this parasite penetrates the mucosa, what is going to happen is that it's going to form an ulcer in the colon cecum, the junction between the colon and the cecum. Okay, or the sigmoid and rectum. Please take note of these two regions for your exam sake. So the ulcers that they form are termed as flask shaped ulcers. That is because of just the appearance of the ulcer. It looks like a flask. Like this parasite will literally penetrate the GIT and then make a hole, especially on the junction between the sigmoid and the rectum, or the colon and the cecum. Okay, and this is going to happen in 10% of cases of with infection. 90% of the cases are normally asymptomatic. These ulcers are caused because of the penetration of the mucosa by the trophozoid. But what helps the trophozoids to penetrate the mucosa? Facilitated by their motility and the tissue lytic enzyme histolysine. They can bring an exam question there. So histolysine is going to be able to break down tissue. It will be able to damage the mucosa, and that's how these will be able to penetrate into the GIT. The metacystic trophozoid penetrates the columnar epithelium cells of the crypts of Lieberkühn. You can see the trophozoids can as well do that, penetrating the columnar epithelial cells. And penetration, as we said, is facilitated by motility, that's movement of the trophozoid. And then you also have histolysine and amoebic lectin. So the lectin of the amoeba allows the amoeba to be able to adhere, to attach to the surface of the intestines. Other virulence factors, these are things that the parasite uses to cause infection, includes the amoebic lectin, cysteine proteinase. So these guys, what they'll do is that they'll inactivate the complement factor C3 and ionophore. Remember, the complement system also protects us. So if it is inactivated, it means now that these can penetrate the body and cause infection. Okay. And we have said that the kind of ulcer that they are going to form is termed as a flask shaped ulcer, specifically in the sigmoidorectal junction, or the cecal, uh, the, the junction between the cecum and the colon. Host factors that affect the course of the infection includes, like, what can worsen the condition if the patient has them. If the patient is stressed, malnourished, takes alcohol, is on corticosteroid therapy, has got immunodeficiency, and this bacterial flora can actually also help in the infection becoming worse. And if someone now has got those flash shaped ulcers being formed, if they go to the toilet, they are going to have bloody diarrhea, and that's known as amoebic dysentery. The symptoms of this dysentery includes mild and can include loose feces, stomach pain, and stomach cramping. So in acute amoebic dysentery, something that is acute is something that has happens there and then. And acute conditions are actually bad than more worse than chronic conditions. We'll talk about inflammation in pathology as the next topic, so you understand chronic and acute. So acute amoebic dysentery symptoms includes abdominal pain, bloody stool, fever, tenderness, rectal tenesmus, hepatomegaly, anemia. What is going to happen is that because someone is having diarrhea where they are losing blood, so there's going to be anemia. Okay, and the liver is becoming also big there, hepatomegaly. Please take note, because in multiple choice question you can see they've put, maybe they bring for you questions where you're supposed to put true or false on each option. They can also put the following are true in regards to the symptoms of amoebic dysentery. They put splenomegaly. You can see there's no splenomegaly here. There's only hepatomegaly. And then chronic involvement of the cecum, like If the cecum is involved for a long period of time, the infection has been persisting for a long period of time, that can cause now appendicitis, the inflammation of the appendix. Actually, dysentery, you have got dysentery that is caused by Entamoeba histolytica, that is known as amoebic dysentery. You also have dysentery that is caused by bacteria, that is known as bacillary dysentery. So you should be able to differentiate these two types of dysentery. Okay. Clinical features of intestinal amoebiasis. The incubation period we said was 4 days to 4 months, but here we've just put 1 to 4 months. The clinical course is characterized by prolonged latency, meaning that there's going to be a long period of time in which you can't see really the features of the disease. They can also be relapse. When someone has got the infection, you treat them, the infection can come back later on. When you compare amoebic dysentery to bacillary dysentery, it is usually insidious in onset and the abdominal tenderness is less. Like this one, at least the bacillary dysentery is not that bad in comparison to the intestinal dysentery. That doesn't mean it is good, but at least in comparison. The stools are large, foul smelling, brownish black, often with blood streaked mucus entangled with feces. Please take note, besides the stool being having blood, it is also going to have mucus because there's destruction of the large intestine. And you know, the large intestines, from your anatomy, your histology, is actually the part of the GIT that contains most of the goblet cells. And why do we have a lot of goblet cells in the large intestines? To make sure that feces can easily flow without friction. So again, some other things you need to know is that you have got what is known as charcoal Leydig crystals that you are going to be able to see. Charcoal Leydig crystals, these are things that you can see here when you get to look at S2 sample. You will be seeing these things. So the differentiating amoebic dysentery from bacillary dysentery, you can look at these features. For amoebic dysentery, normally the audio is offensive. Bacillary, the one caused by bacteria, it is odorless. Amoebic is dark red, and then bacillary is bright reds too. And then in amoebic dysentery, there is blood and mucus mixed with feces, while in bacillary dysentery, there is blood and mucus but no feces at all. And then when we look at microscopic, the red blood cells are going to, they are in clumps, reddish and a yellow in color. While in bacillary, they are forming a Rolex. You know, a Rolex is the blood has come together like that, and then it is bright red in color. This one was yellow. And then pus cells are scanty in amoebic dysentery. Pus cells, these are basically white blood cells. And then when you look at the parasite, in amoebic dysentery, there's two are going to see trophozoites of Entamoeba histolytica. For bacillary, you will not be able to see them. Why? Because this is not caused by the tropho or the Entamoeba histolytica. And then charcoal ready crystals you'll be seen in amoebic dysentery and not in bacillary dysentery. The extraintestinal amoebiasis, this is where the other parts of the body are involved. You can have the liver, hepatic amoebiasis, pulmonary amoebiasis, metastatic amoebiasis, cutaneous amoebiasis, genitourinary amoebiasis, and these other forms of amoebiasis getting to happen. Okay. So these others is just the involvement of other parts of the body. And by far, the hepatic amoebiasis is more common in comparison to the others. That is one thing that we should be able to know there. So hepatic amoebiasis, what happens here? So in hepatic amoebiasis is actually the most common type of extraintestinal amoebiasis. And here, what is going to happen is the liver is the one that is involved. Specifically, you need to know which part of the liver is involved. The posterior part of the liver, specifically the right lobe, and specifically the upper part. Okay. So posteriorly on the upper right lobe of the liver. And what you are going to see is that there's going to be formation of liver abscess that contains odorless and thick chocolate brown pus known as the anchovy sauce. Okay. So by far, hepatic amoebiasis, we are saying, is the most common type of extraintestinal amoebiasis. Please take note of the appearance of the liver if it is involved, the anchovy sauce pus. You can see the way it's looking. There is actually an abscess being formed. And this amoebic liver abscess is associated with abrupt onset of high fever, right upper abdominal pain and tenderness. There's going to be pain in the abdomen. And then if someone has got hepatic amoebiasis, there's also going to be anorexia. They don't have appetite. Okay, loss of appetite. There's also nausea, vomiting, fatigue. There's also weight loss. Weight loss is making sense because the person doesn't have appetite. You need to know these symptoms. So sometimes someone can have no history of amoebic dysentery, like they don't have the involvement of the intestine. There's no history that they had involvement of the intestines, but now they have got liver amoebic hepatic dysentery. So that can also happen. Pulmonary amoebiasis can as well also happen, and the manifestation when the lungs are the ones involved, there's going to be pruritic chest pain, which can be severe, dyspnea, this is difficulties in breathing, and a non-productive cough. Metastatic amoebiasis, metastatic just means going to distant organs which are very far from where the infection had started, like for example to the kidney, to the brain, to the spleen, to the adrenals. This can all be seen. They can also be cutaneous amoebiasis, also penile amoebiasis if there is anal intercourse, because the interamoeba histolytica is part of the GIT. So for the what do you call those people that marry their same sex? Okay. So how can you diagnose if someone has got amoebiasis? You can look at the microscope. You can look at the trophozoites in freshly passed stool. You can look at the red blood cells that have been engulfed by the interamoeba histolytica, so you can see them in the trophozoite. You can use the iodine stain preparation to demonstrate the cyst or the dead trophozoite, iodine stain preparation. And then macroscopy, like without you using a microscope, you're just looking. The stool is normally brownish black. It is foul smelling and it has got blood and mucus. Okay, so you can see this is a trophozoite that you'll be able to see. You can see you have got four nuclei inside. That's the quadrinucleate cyst. And then you can also look at the trophozoites which have got red blood cells inside them. You can also do a stool culture. Culture is you've gotten the stool and then you're trying to grow the parasite so that you can be able to identify. This is a very sensitive method in diagnosing chronic and asymptomatic intestinal amoebiasis. Actually, culture is a very good method. You can also look at blood, okay, diagnosis, especially actually it becomes positive only in invasive amoebiasis, because it's only the invasive form where you're going to find the bacteria, the parasite in blood. In the non-invasive, is still in the GIT. So you can look at blood to be able to see these guys, and you can also look at their antibodies. And then to diagnose the extra-intestinal amoebiasis for the liver, you can do a liver biopsy. You get a piece of the liver. You can also do a pus aspirate from the abscess to be able to see if there are trophozoites there. Radiological examination is useful for the diagnosis of liver, amoebic liver abscess. Okay, you can also do the radiological exam, like if the liver has been involved and there's an abscess there. On the treatment of amoebiasis, you have got some drugs that will only work in the lumen, meaning that they only work for those diseases where the parasite is in the GIT lumen. Those are known as amoebic luminoamebicide. If you see a drug that uh, side at the end, that means that this kill that thing. For example, bactericidal, they kill bacteria. Amoebicidal, they kill amoeba. So luminoamebicides include iodoquinol, poromocine, tetracycline. You can also use metronidazole and tinidazole, but metronidazole and tinidazole, you see most of these are very good drugs, by the way. They work for a lot of infection. And the goodness is that metronidazole and tinidazole, these guys can work for both infection that is in the lumen or in the tissue. That's the goodness for metronidazole and tinidazole. And then drugs that can only work for tissue infections include the emitin and chloroquine. Chloroquine is this guy, you can also use it to treat malaria. How you prevent infection caused by interamoeba? Avoid the ingestion of food and water contaminated with human feces. Treatment of asymptomatic patients with who pass histolytica, cyst in the stool. Vaccination, till now there is no effective vaccine that has been licensed for humans. So that's not something to worry about. Make sure that you improve sanitation, water, food contamination, health education, also improve personal habits to help in the control. And also detecting and treatment of carriers can also be helpful. So that is it, my friends, on amoebiasis.